Signori, ragazzi,
Bambini,
bambini,
Ragazzini,
are you ready? Happy birthday.
Happy
birthday
birthday,
to you. Happy
happy
birthday
birthday to
to
you.
you.
Happy
Happy
birthday.
birthday, dear
Happy
Costantino. Happy
Happy
birthday
birthday
to
to
you.
you.
Thank you, my friends. Thank you.
Eh.
He's 40.
Yes.
Forti,
40.
forti,
Costa,
mamma mia, mamma
I'm
mia.
sorry to tell you that you are not anymore the young generation of unfortunately.
I feel
No,
it. I feel it,
no,
my friend. I feel it in
no.
my bones, actually.
No, now you have to look for a nice girl to marry and to make 5 children, you know? It's time for you to get a family.
Settle down. Yes, yes.
Absolutely, JP. We are waiting for that. Konstantinos.
Come on, you're not a child anymore. You have to become serious. You have to get married. You have to.
Yeah, yeah. I mean, what should you do? You know,
Basta.
basta giocare,
Oh,
basta giocare.
Bambini, basta con. How do you say that?
con
Basta
questa.
con la palla, basta con la palla. Okay, okay, but where are you, Costantino? Where are you?
I'm in Halkis, my hometown.
Ah, perfetto, perfetto.
Mm.
Wonderful.
I was watching before the first set of the final of the tennis tournament, Sinner versus Alcaraz. Unbelievable.
Yes, but Sinner is unrecognizable. He's
No,
not
no,
playing good.
he was playing very well in the first one. They were both.
Yes, but now Alcaraz is just doing whatever he likes. We
Yeah,
are 3-0 or 4-0?
yeah,
4-0, 4-0 in the second set. So
yeah.
almost finished. Anyway.
But
Ragazzi, so we have to the geography
wait, but
today.
before this, what else do we celebrate today? Nisa, we celebrate the championship of
Galatasaray.
Galatasaray.
Ah, champion.
Champion.
But
Today,
Congratulations.
we're going to announce our championship
it's done.
Okay.
25 times.
So it's done. It's sure. You won.
Yeah. And,
Okay.
and from now on, we have the five
Oh,
star. Now 4 star, and now today we will be 5 star champion.
Every
ah,
year, one of our teams wins the championship. Last year, it was my turn. My team won the championship in Greece. This year, Nisa's team wins the championship in Turkey. And very probably, Napoli will, very probably, Shh.
you don't have to say it loud.
Don't jinx it.
Yeah. No. And
And
this evening, there will
Napoli.
be, yes, this evening there will be a very important match, to understand if we are able.
It's just
Good
one.
luck, Napoli. We
Yeah.
support Napoli.
Bene. But Emilio, did you prepare yourself for the geography today?
Of course, yes.
Yes, come on. We need to do a little bit of geography. We have people from Russia,
You tell
from
me and I mark. Okay, you tell me and I mark. Okay, Russia,
okay. So from the beginning, Riga,
Riga,
Hungary,
Hungary.
Russia,
Spare, wait a moment. Yeah, Russia. Yeah, okay.
Dakar.
What is Dakar?
God,
Dakar is
somewhere in Africa.
Morocco, no?
No, is it?
Parigi-Dakar is Morocco or Morocco, I suppose.
Wait, come on.
Senegal, Senegal.
Okay,
Senegal.
check, Sebbi, check.
Ask Jen.
Romania,
Senegal.
New Zealand,
Wait. Romania.
New Zealand,
Okay.
UK.
Okay.
Morocco.
Uzbekistan, Morocco. You see, I'm good in geography. Uzbekistan,
Wait a moment. It's here. It's here. Okay, good.
Turkey,
Turkey,
Argentina,
Argentina.
Azerbaijan,
Wait a moment. Wait a moment. Azerbaijan. Azerbaijan. Yes.
okay, Canada,
Yes.
And
Wales, okay,
USA.
Wales. Anyway, you have it. Romania again, Ukraine, Nigeria,
Nigeria. Yeah.
Nigeria,
Yeah.
Cyprus,
Yeah.
El Salvador.
El Salvador.
Yes.
Uh,
Nice.
France.
where am I? Where is
It's
El Salvador?
it's a tiny
Salvador.
country. Go a little bit more down, more down. A bit more up.
Yeah.
Panama, Costa Rica.
Costa Rica. Where is it?
Okay, found it.
Okay.
There
El
it was.
Salvador found. Lebanon, Beirut,
Lebanon.
Serbia,
Lebanon. Serbia. Where is Serbia? Serbia. Serbia.
Serbia.
Since you're there, Greece as
Bulgaria,
well.
Bulgaria.
Greece. Bulgaria.
Chicago, so US.
USA.
You see, with one click, we get, especially with Russia.
Italy.
Yeah.
Austria,
Austria.
Poland.
Peru.
Poland. Wait a moment. Poland. Peru. Peru should be here. Yeah.
Mexico,
Mexico. Yeah.
Norway,
Norway.
Brazil,
Brazil.
UAE.
United Arab Emirates.
Yes.
Here.
Where's
Sweden,
Australia?
Australia.
Sweden,
Sweden.
Libya,
Libya.
Georgia,
Georgia.
Senegal,
Mm, wonderful.
Germany,
Yeah.
Uzbekistan.
Uzbekistan is done.
Okay, Estonia.
Lebanon?
Done.
Yeah,
Okay.
we have
Well,
Austria.
Blandin, Africa. Africa is a little bit too much. Dakar is in
Nicaragua.
Senegal.
But we do have
Ragazzi,
South
I'm
Africa.
Nicaragua.
sorry.
What?
Nicaragua.
Nicaragua. Okay.
Macedonia,
Okay.
South Africa.
Morocco, Spain,
Yes.
Croatia.
Dubai,
Germany.
Croatia.
France.
Croatia. Dubai. Done.
France.
Macedonia.
Done.
Okay,
Where is Pascal? France.
France. Done.
Venezuela,
Venezuela.
Ecuador.
Ecuador, yeah,
Wait a moment. Venezuela. Okay.
Ecuador,
Ecuador.
Greece,
Ecuador. Greece. Done.
South Africa, done, Nicaragua,
Done.
Mhm.
France, Brazil, Venezuela, Germany, Croatia.
We need
What
Portugal. We
else?
need Finland.
Portugal.
We have
Where
Portugal.
is Portugal? No Portugal.
No
Not
Portugal,
yet.
not yet.
We need Czechia, we need Slovakia, we need Belarus, we need Lithuania, we need Finland,
Eh,
We have
Iraq.
Switzerland,
Iraq.
Iraq,
Iraq,
Iraq, and Switzerland as well.
Switzerland. Wait a moment.
Switzerland.
Switzerland is here. Iraq is Iraq.
Under Turkey.
Okay. Done.
Nobody from India, yeah, nobody from India.
Nobody from China for sure.
Yeah, we would like a China because look, it's a
Look
big.
how
Yeah,
big it is.
yeah.
Well,
And
wow, look at this.
Come on. Belgium, Netherlands, Luxembourg. Come on, guys. Denmark.
Guys, at least Europe. We need to color it.
We need the Paesi
Brilliant.
Bassi.
Albania. Come on. Montenegro.
Yeah.
Albania, we have it.
Mm.
Ah, perfetto, perfetto. Groenland, Groenland. We don't have anybody from
From Greenland.
Greenland. Okay, 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 guys. So I suppose that we can launch the question of the week perché today, as announced very frequently the last period, this is the last episode of season number 4. Ah, season number 4. Are you going to miss us? Not at all. Yes, a little bit. Yes, immensely. I'm going to miss mostly Sebby.
I'm going to miss mostly Sebi.
Yeah, 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 yeah. Ah, yes,
Oh,
immensely. Mamma mia.
Sebi.
Sebby, you got your 13
Oh,
votes, you know? Yeah, yeah, yeah. It's not bad. It's not bad. Yeah.
My fan club.
Okay,
and
take
there
a
are 8
screenshot.
people there. They will not miss us. Who are those 8 people?
Yes, but they are joking. They are joking. They are already crying, you know? I'm
Let's
also,
uh, a screenshot of the map.
yes, please do.
yes, yes, yes.
Yeah.
Let's do a screenshot. You know that this weekend we've been in Bucharest with Emilio and Iris, and
How was it?
we had a nice course, and we left basically Hassan Galadari and Yolanda,
Gilaberte.
yes,
But I leave the map open because I see that new countries still arrive for
yes, 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 yes.
Colombia,
Colombia, for example.
and we will check again in the end.
Yeah.
So if there is somebody from additional countries, send us something in the chat.
Yes. Okay. Yes, and we realized that because on the Saturday we had a course on dermoscopy, skin cancer, oncology, inflammoscopy, and on Sunday they were speaking about cosmetology, and we realized that Emilio is an expert in biostimulation.
Mhm.
But I mean, you asked me to on stage to explain you what is biostimulation,
Yeah.
and I successfully explained what is
Yes.
biostimulation.
Exactly,
And you
exactly,
did not expect that I will be able to answer. That's
exactly.
yeah, that was your problem. You
Yes, yes, yes. So
thought
I
that you will expose me. Why?
exactly. Yeah, yeah. I was impressed. I was impressed.
Guys,
And it's a shame for me. I have no idea about biostimulation.
what is biosimulation? PRP kind of thing?
No, no,
I
no.
cannot explain again. I mean, I
Yeah,
explained yesterday. I mean,
yeah, yeah, yeah. There is a lot of things ongoing in this field. Anyway, so I suppose that Sebby sent cases to all of us, right?
Yeah.
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 So who's going to start?
Birthday boy.
I
Birthday boy.
I suggest
Boy,
Constantinos.
birthday boy. Yeah.
Okay.
Happy birthday.
I will start with the one that you sent. This case is for me. Give me just 1 second. By Dr. Roxana Janet.
Cuba Libre style tie.
Yes.
So that's nice.
So, a 57-year-old patient was hospitalized in the internal medicine and dermatology department of the military hospital after returning from Cuba due to a primarily abdominal pustular eruption, oligoarthritis, left wrist, right ankle, and right foot, and anorexia evolving over 3 weeks. Past medical history includes ischemic heart failure, hypertension, and type 2 non-insulin dependent diabetes. Treatment in Cuba involved NSAIDs, corticosteroids, and ciprofloxacin with partial symptom improvement. And this is the initial image IS. During hospitalization, skin lesions disappeared while other symptoms worsened, presenting as polyarthritis. Fingers, left knee, right hip, ankles, feet, and fever at 38.9 Celsius. Synovial fluid aspiration from the left knee revealed 1,300 nucleated cells. Wow. Composed of 95% neutrophils and 5% lymphocytes. Direct examination found no microcrystals. Culture on standard isolation media was sterile. Laboratory tests showed an inflammatory syndrome with white blood cells at 14,000, neutrophils at 11,000, so 80%, PCR at 114 milligram per liter, and normal liver and kidney function. Autoimmune screening was negative. HIV, HCV, HBV, and syphilis serologies were negative, as were dengue and chikungunya serologies. I love chikungunya.
Okay, so at least we can say probably it's an infection, right?
Yes, an infection. Cuba.
Yeah.
I haven't read the case, but okay, infection. We can think of tropicals. I would go to either tropicals or STDs.
Yeah.
Urine culture and blood cultures performed routinely and during fever spikes were sterile. Cardiac ultrasound showed no evidence of endocarditis, and thoracoabdominal pelvic CT scan revealed no signs of neoplasia, deep infectious focus, or bone lesion. MRI of the sacroiliac joints and lumbar spine was normal, as was the whole spine MRI. Faced with an unclassified polyarthritis picture, corticosteroid treatment was started at 20 milligram per day. Subsequently, symptom improvement was noted, but after 2 weeks of corticosteroids, a fluctuating inflammatory swelling appeared over the sternal manubrium.
Oh,
Wow. Wow.
oh my God. A big
So,
abscess.
what would you do next? I guess they did a CT or what? Yes, CT and PET scan. Progressive sternal osteitis with extension to subcutaneous tissues and inflammatory or infectious process of the right hip joint. Okay, interesting. Look at this mass, guys.
Yeah.
Crazy.
Yeah. It's big.
Yeah. A puncture biopsy of the pre-sternal collection was performed. Cultures were sterile, but PCR was positive for Neisseria gonorrhea.
Yeah, you were right. Yeah, STD. Yeah.
Wow.
No way. Yeah, I understand.
Upon further questioning, the patient admitted to a risky sexual encounter during his trip to Cuba. Serologic testing for HIV, syphilis, and hepatitis was repeated and remained negative. Gonococcus and chlamydia PCRs on urinary and pharyngeal samples were negative. Notably, the patient never experienced urethritis. One thing to remember that occasionally, yes, Neisseria can give systemic symptoms without urethritis. Rare. I think it's less than 5% of the cases, but still can happen.
Yeah.
A central venous catheter was placed and treatment was ceftriaxone 2 grams per day was initiated for 6 weeks. CT at the end of antibiotic treatment showed favorable progression with disappearance of pre-sternal infiltration. And follow-up at 1 and 2 years showed no recurrence or sequelae. Flirted with disaster, somehow disaster ghosted me. And house, don't ask why patients lie. I just assume they all do.
They all do.
Nice.
Wow, fantastic.
Amazing case.
Very
Amazing.
nice case. Very nice case. It was a case for Dr. Ramos. Yeah.
Yeah. Amazing case. Yeah.
Very nice. Amazing.
Claudia says Sapho syndrome. Is this a Sapho syndrome? I don't remember.
No. Sappho is in the spectrum of acne.
Uveitis,
Pustulosis,
Yeah. So
ostate, sinoate, sinomitis.
yeah.
Fantastic.
Okay. Wonderful.
Anything else, Konstantinos?
No, I think this was the case for me.
Okay. So Nisa?
Okay. Let me. And the first case is from Mirjana Popadic from Serbia.
Mhm.
The patient is a female, 71-year-old, and there's a dark plaque on the left breast. It's a long-standing lesion over 10 years and recently darkening in color. This is a lesion
Mhm.
on the breast. And this is dermatoscopy.
Mhm.
This is non-polarized. This is polarized mode.
I
And
think
what's your diagnosis here?
I think it's the opposite. I think this one is non-polarized and the previous was
It's
polarized.
non-polarized. This is polarized.
Yeah,
This one is polarized. This is non-polarized.
yeah, exactly. Exactly.
Any guess?
Seborrheic keratosis like blue nevus.
Jeffrey?
With familiar-like cysts.
Of course, if she is presenting this case, this is not only a seborrheic keratosis, but let's see, vertical ex vivo confocal. No,
Yeah, and this is vertical ex
dermoscopy.
vivo
Ex vivo
dermoscopy. Yeah,
dermoscopy.
not confocal. And histopathology was blue nevus.
Ah, okay.
Yeah, she was surprised with the diagnosis and she wrote in the email. And the second case is from Gary Levy, Israel. He also asked this patient to me, so I know this patient. The patient is a 72-year-old lady with a history of 3 years, and it was enlarging.
And there's
This is the
I can see
dermoscopy.
Nisa from the previous image with a lot of
Yeah.
more because there is the marker number 120.
You are very careful, yes. Probably she has a lot of nevi at the same time. And this is a polarized dermatoscopy. There's a flat pigmented lesion. And this is the close-up of the polarized mode.
Yeah.
And this is non-polarized mode, non-polarized, polarized, non-polarized, polarized. What do you think it is?
Tough to say because we only see a pseudo network here.
Yeah.
Yeah.
Maybe a few small dots and globules, which if it's true, then it's a sign for lentigo maligna. But
Yeah. It's one of
And
these
the
lesions
first,
which, yeah.
he made a biopsy, and the first report was atrophic solar keratosis with solar lentigo in sun-damaged facial skin. And of course, he didn't convince with the diagnosis and requested deeper sections and immunohistochemistry. And after immunohistochemistry analysis, the lesion was PRAME positive, and the diagnosis of lentigo maligna was performed in this case. So when we have suspicion, maybe we can need second opinions or immunohistochemistry or deeper sections for such suspicious lesions. This is a good example for this topic. And we have a question to you. This is a very recent case. The patient is a 35-year-old male. The lesion is there since childhood, but it was growing since the last 3 years. And this is the lesion, and here is a close-up. And this is dermatoscopy, polarized and non-polarized, as you can see. And this is with hand dermatoscope. The color is bluish. And this is with sub-UV mode. We have nothing in sub-UV mode, so we can understand that all the pigmented melanistic things nests are located in the deep dermis then, because when there's pigmentation in the epidermis, it looks black with sub-UV mode. So we can understand that it's a deeper one. So what's your diagnosis here?
Well, of course, first thought is going to blue nevus.
oh, yeah.
Yeah, definitely.
Yeah, definitely. I also think about blue nevus because of the this sub-UV mode. But since the patient was saying that it was growing and changing, I would like to take a biopsy from this lesion, and almost totally excised by the plastic surgery department. And histopathology was here, melanocytic dermal nevus. not blue news.
Okay.
And I just want to mention that the patient is a skin color 5 in this patient.
Okay.
And sometimes in skin of color patient, we can also encounter this bluish color in the skin types. Good for the patient, but I think it's a good example, educative lesion for discussion. Thank you.
Yeah.
Excellent.
Wonderful.
Fantastic.
Well, the case by Gary is underlying again and again and again. The problem of the differential diagnosis of facial lesions is not only clinically but also histopathologically.
Yeah.
So we have to take decisions based on what is our, let's say, overall suspicion, you know. So if we strongly suspect lentigo maligna, as probably Gary did, it's useful to get a second opinion, or to even to behave like it is a small lentigo maligna, because at the end of the day, I mean, the treatment is not so dramatic. It's a small lesion. You can excise what you see, and then you do a little bit of imiquimod. Yeah. Bene. Who's going next?
So I have two more questions,
Yeah.
two more cases that I didn't see. So
Okay. Okay.
In
There is,
the
by the
meanwhile,
way,
off-topic question: when do you recommend genetic testing for melanoma susceptibility genes? How many family members with melanoma, which degree relatives have to be affected? Quick answer: the rule of three or the rule of two, depends what you want to select. The rule of three meaning 3 primary melanomas in the same individual, or 3 cases of 3 people with melanoma in one family. If you apply the rule of 3, then the percentage of tests that are going to be positive, of course, this depends on the population. The percentage is somehow
acceptable.
Reasonable, acceptable. If you do it with the rule of 2, which you can, of course, but then the number of negatives will be huge. So in the vast majority, you will do the test for no reason.
Yeah.
And also, there's a very nice paper showing that if there's a family member with a history of pancreatic cancer
Pancreatic cancer,
Yeah.
yeah, exactly. That's what
and one melanoma, there's more than 70% probability that you will find CDKN2A. So pancreas has a huge weight in
There is a connection, yeah, definitely. But we also follow the rule of 3 because I mean it's really with two members it's not enough, let's say. So it's extremely improbable to find a positive test. Vai Costantino, vai.
Bye. Oh, from Michael Christopher from Tucson, Arizona. Hi, Michael. Middle-aged female presents with this lesion of concern on her chest. Clinical exam reveals a pink to lightly tan irregular patch with slight scale. Dermoscopy reveals the following. Here we have polarized and non-polarized dermoscopy. I will take the liberty to describe. We have some polymorphous vessels, some globules, and background sun damage. Here we can see it even clearer, and some shiny white lines, as we can see here. So I will go, I'm not going any further, I don't know the case. I will go for a melanoma 0.6, 0.5. Emilios?
I would check in the chat. What's your question, my friend? Diagnosis?
Yes, I said.
Yeah, melanoma. I agree with you. Microinvasive. Yeah.
I said 0.5. You say?
Yeah, come on. 0.4.
Debbie?
Yeah, I agree.
I agree. And Nisa?
Melanoma 0.3.
Okay. So here are the different aspects.
Yeah.
Pigment BC, pigment CAS, pigment lichenoid keratosis, or invasive melanoma.
Melanoma, yeah.
Point
0.4.
four, point four.
0.4.
Bravo, bravo, bravo.
0.3 is also okay. Maybe
Nisa, don't get jealous, my love. Uh, and Michael describes really nice the lesion here with the shiny white lines, absent non-polarized dermoscopy, linear and dotted vessels, mostly with some coiled vessels. And here we can see them zoomed in, and large irregular globules. Excellent. And we have another case from Joanna.
Bathing trunk nevus.
Bathing trunk nevus. 25-year-old man born with a bathing trunk nevus, otherwise healthy, hasn't visited the dermatologist for the last 24 years. Just for the audience, although I think that they all know it, bathing trunk nevus is the distribution of a giant congenital nevus.
Mm-hmm.
So, let's see.
Yeah, yeah. Whoa.
Yeah.
Wow.
Wow, it's almost everything.
Wow. Yeah.
Wow.
Yeah.
And here we see 171 markers. Oh my God.
Oh, there's a mess there. What's that?
He got also some surgeries, some treatment, you see.
Mm.
Yeah. And here we see dermoscopy.
Do you think that dermoscopy is of any help in this scenario?
Me,
No,
Well, I mean, you can pretend to do dermoscopy, but actually it's almost
yeah.
impossible to screen everything. But also,
Especially when there is a lot of hair.
and
It's
because
impossible to see.
of melanoma, which is
Mm.
appearing in the deep subcutaneous,
Mm.
the deep dermis.
yeah, I agree. And I mean, I totally understand why they did 170 markers in
Yeah.
order they are over the patient and everything. But yeah, imagine seeing that patient back. You'll do another 170 takes, and in essence, you're not offering big help. So let's see the dermoscopy. Here we see a kind of a reticular, a bit globular pattern. Here, vessels and some shiny white lines. Globular pattern, globular and homogeneous. And here, some scar-like areas. A
Mhm.
lot of dotted vessels and homogeneous blue. Wow, such a heterogeneity. Here, very worrisome, I guess.
Yeah.
In the dermoscopic examination, there are many hypopigmented patches with symmetrical distribution of dotted vessels, many lesions with scar-like depigmentation. The dermoscopic pattern of the bathing tract nevus is very heterogeneous with globular pattern, reticular pattern, homogeneous, and a combination of the above. Any practical tips for the dermoscopic examination of this patient?
Yeah.
I think that we already gave the
Touch
tips.
the lesion, touch the lesion,
That's
touch
touch.
the lesion.
Yeah.
Yeah. Yeah, it's really a patient that we don't like to manage at all, right? I mean,
Yeah, yeah.
really difficult. Anyway, okay. So you for
Okay, another question
yeah,
is among nevus-associated melanomas, which percentage are Clark associated and which percentage are congenital nevi associated? If we have the time to answer. Yes, and we have this answer. We have this answer. I can show you.
yeah.
Uh,
Majority is for congenital.
Not the majority, but so that's
Well,
that's the
majority for congenital if we include dermal nevus in the family of
yeah.
congenital neva.
Mm.
Yeah. So that's the meta-analysis. Of course, 71% de novo and 28 on pre-existing nevus. Okay, thinner than de novo melanomas. And that's the answer to the question. So you see that we have here 471 melanomas in congenital nevi, 1,612 in acquired nevi, so 75-25. But if you consider how much more frequent are acquired nevi, then obviously there is an over-representation of congenital nevi here, obviously. And then, yeah, if you include dermal in the congenital group, then this 25% is going to become 50%. I don't know. And to the other question, you see that the majority of nevus-associated melanomas, the nevi was not dysplastic in the majority. In the minority, it was reported as a dysplastic nevus. So that's the answer to the question. Yeah, and if you I repeat, if you consider the frequency of congenital nevi and the frequency of Clark nevi, there's a big difference in the two frequencies. Then we can conclude that congenital nevus is, let's say, the only nevus which has a considerable risk of a melanoma developing inside the nevus. Therefore, it merits some kind of special attention, which is not the case for acquired nevi. What else?
So,
should I go, JP?
Yes, Emilio, go. Go, Johnny, go.
So, I have a nice case from Verce. Male 27 with familial melanoma history, first visit, total body photography and so on, and 2 melanomas, despite of the age. That's the first one on the scalp.
Wow.
Shiny streaks, blue color. Then these comedal-like openings.
For example, in a patient like this, if you do the genetic test, for sure it will be positive, you know.
Yeah, because she says also it was a familial melanoma history.
Yeah.
No, but I was commenting that we were discussing yesterday in the course that scalp melanoma often acquires some characteristics of keratinization, looking a little bit like seborrheic keratosis, clinically and dermatoscopically. That's often the case with scalp melanoma, and we should keep in mind. And then the second was here. I would say that this is a spitzoid melanoma in my view. I mean, there is also this negative network, some kind of strict pseudopod, so spitzoid morphology, spitzoid melanoma 0.8. And third follow-up, 12 months later, you see a mole that increased in size significantly and also in color, became darker. You see the baseline and the change. And here you see the morphology.
It's spitzoid.
Again, somehow spitzoid. I mean, you see the black globules together with the brown globules and some kind of negative network. So a bit ugly again. And once again, micromelanoma 0.8.
0.8.
Yeah, that's a lot. I agree. But look at the ruler. You can see that the diameter is 1, 2,
maybe 3 millimeters, less than 3.
3 millimeter.
3 millimeters. 3 millimeters. Yeah.
And it's changing, growing.
Yeah. Of course, it's good, Verce, that you don't read the New England Journal of Medicine, because if you did, then you would probably read this paper that says that you should not excise lesions smaller than 6 millimeters. Thank God that you don't.
Yeah.
Okay, very good. So that was the
Great
first.
cases.
Very good.
And the second that I have to show you is this. Kezia and Anya. Kezia and Anya. Multiple, that was very nice, by the way. Multiple onychopapillomas. Could it be something more? Look, so we have a 40-year-old patient that we presented for examination. And then on the hands and feet, they find multiple linear leukonychias in many fingers, nearly all the fingers and the toes. And you see here the clinical aspect. You see these lines that are visible clinically, and then dermatoscopically, look, I mean, they are onychopapillomas. It's clear. Yeah,
Yeah.
it's onychopapilloma, onychopapilloma,
Mhm.
onychopapilloma. Yeah. So multiple onychopapillomas. This patient had also a history, despite of the 40 years of
Mhm.
age only, he had a history of renal cell carcinoma and was tested positive practically for the BAP1
Hmm.
and reported also family history of melanoma and pleural mesothelioma. So multiple onychopapillomas associated with BAP1 tumor predisposition syndrome were described in one study, and probably should be a reason to search for the germline mutation, according at least to what Kezia reports and what she
Yeah,
found
yeah.
in her literature search, which I have to say that I didn't know. So it's something
Yeah.
that I learned today.
Ac- Yeah, actually, I knew that because I had a very similar patient like this, and he had also BAP1 mutation. But what's interesting is, Milos, can you go back to the dermatoscopy?
Yeah, before this, I just wanted to mention that they submitted this case to DPC. Just mention it in case the editor is listening.
Listening.
Just mention
Rejected?
not trying
Ah,
to apply any kind of
No, 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 no,
pressure.
no. Clear,
Just
clear,
mention it.
clear.
even in one nail, there are three onychopapillomas.
Yes,
Did you see
Yeah.
that? This is so
Impressive.
interesting.
yes,
Impressive.
yes, yes.
Well,
Not only
maybe,
involving multiple digits, but also three onychopapilloma in one digit. This is so interesting.
yeah.
Editor in chief.
No, no, this is definitely a great case.
Great
Is
case.
there, could it be a question related to HPV? Maybe. I don't know.
Now the point is if they are a phenotypic expression of the germline BAP1 mutation.
Yeah, yeah, yeah,
That's
yeah,
the question,
Yeah,
yeah, of
which is
course,
interesting to
of
uh,
course.
great cases.
yeah, yeah.
Yeah.
I had no idea. I hadn't seen the
Yeah,
paper.
I also have no idea.
Wonderful, wonderful.
Wonderful, wonderful
Well,
case.
I also have three cases which I find extremely nice.
Joanne asks before this, JP, if
Yeah,
we should remove uh, the the onychopapillomas. I would say no, no. The onychopapilloma itself is not a problem. The problem is
The
uh,
bubble mutation.
yeah, the germline mutation that predisposes to cancers. And there is another question that I do not accept in the chat. Come on, now I'm getting angry. There is a question, what is DPC?
Oh my
Come on,
God.
Epic Sal.
Oh my God.
look at this, look at this.
Is it clear enough
Epic
or
Sal.
should I take
What
it
is
Oh.
off?
DPC? I mean, no, no, no. But I mean, this is an important question. Yeah, we have to make sure that all our people know what's going on with DPC, dermatology, practical and conceptual. Yeah, it's the journal. It's the journal. Yeah, the journal of the International Dermoscopy Society, the only journal in the world where nobody's paying
Oh, in the universe, also
in the universe.
in
Yeah,
the other planets, there is no journal. It's not only
And
Earth.
it's Q2
yeah, yeah, yeah. It's
The
in
only journal
Q2
you should
index.
publish.
you too. And so it's a free access, it's open access, but also the authors are not charged because of the generosity of the International Dermoscopy Society. Yeah.
You know, the next step is going to be that the authors will be paid.
That's the next step. And also the readers, also the readers. Okay, so Antonella, our friend from Trentino Alto Adige, she's a very good friend and an expert in dermato-oncology. She was really very nicely documenting this lesion, which I find extremely important for learning a lesson. This is a 55-year-old man, phototype 2, with not many nevi. And this is a lesion appeared 3 years before on the right lumbar spine. Since 6 months, there is a new exophytic lesion in the center, and that's why the patient came for consultation. You see, I mean, clinically, it's really nothing special. It looks like a congenital nevus with a dermal component in the center.
Yeah.
Nevoid melanoma.
Yeah, shortly before the hematology visit, the diagnosis of STEMI in type 2 diabetes. Okay. And this under metoprolol. It's a selective beta blocker for his disease. And this is what we can see dermoscopically. Uh, I mean, the flat part is not really too much interesting. Maybe on bottom right, there is some kind of vascularization, but the rest is a very tiny network, I suppose, or structureless brown pigmentation. But the dermal, the nodular part is made of this cobblestone pattern, but it's a funny looking cobblestone because it's made of bluish and reddish no areas. So the lesion per se is not very easy to assess, but definitely from this particular morphology, one can say, okay, it's still a dermal component in a congenital nevus, but it's not. This is a polypoid melanoma. You are right.
Wow.
Polypoid melanoma, Breslov 3 millimeter. So it's a bad melanoma. It's a very bad melanoma.
But I missed the beginning of the description. That was a congenital nevus, the flat one?
Well, no. This was reported to be there since couple of years, and then the nodule appeared a few months before.
Uh-huh.
Yeah, yeah. So this is the reason you see this histology, and this is the reason why the lesion looks polypoid and with this cobblestone appearance. There was anyhow already a lymph node metastasis without extracapsular extension, and therefore I suppose he did adjuvant treatment.
No, he did the lymphadenectomy.
Lymph nodes and all negative. Okay, he did no adjuvant therapy for cardiological problems. Okay, so he did not undergo adjuvant. So after 9 years, no recurrence. So this is very good. Protective effect of beta blocker. This is a very good question. I remember very well that a few years ago we started empirically to before the era of adjuvant treatment, we started empirically to use propanolol for adjuvant treatment of high-risk melanomas because of a few papers showing that propanolol has a protective effect against melanoma metastasis. But this was never proven, let's say, in a randomized trial. So, I mean, this remained basically an unexplored medication. Okay, second case. This is, I show you immediately the case because I want to hear your opinion. That's the lesion. She was coming basically to treat the lesion cosmetically because she was annoyed by the lesion. And that's what you can see dermoscopically. I mean, clinically, it's a dermal nevus or a seborrheic keratosis, right?
Yes.
Yeah.
Yeah. Well, dermoscopically, then it's becoming a little bit more complicated in my view because there is a lot of blue color. Still,
Yeah.
this blue color can be related to the to the dark skin type of this lady. She's, I suppose, skin type 4. But still, I mean, this is a lesion which is not really roundish to make a cosmetic treatment only. So that's why the lesion was, I suppose, shaved for histology. And no, it was excised actually, and pathology revealed a BCC. Huh?
This, okay.
BCC, yeah. In this case, is from Vittorio Tancredi from our group. Yeah.
Okay, good.
Yes. Okay, and the last case I want to show you is this one. Acne, right?
Steatocystoma multiplex,
Ah,
something like that.
okay. This is an option. Let's have a look of other parts of the body of this patient.
Hidradenitis as well,
Yeah,
maybe.
There don't need this.
But there is
Mhm.
something more here, and probably this is the clue to the diagnosis. Look
So,
at this.
Follicular
follicular and
hyperkeratosis.
Yeah,
Folliculotropic mycosis fungoides.
exactly, exactly.
Yeah.
This is folliculotropic mycosis fungoides, which is impressively connected to the sebaceous. I mean, there are a lot of look. I mean, this really look like sebaceous stuff, you know. So there
Mhm.
is a lot of epidermal cysts. There is a lot of acneiform lesions, hidradenitis type.
Probably syringotropic as well. Folliculotropic, syringotropic, both type.
Exactly, but we have to remember that in a patient like this, which is not anymore in the range of of an acneiform rash, I suppose that he is let's say uh, judging by the hair of this patient, I suppose is definitely not less than 50. We have to make sure when we see these things which are on one side pointing to a acne-like disorder, that this is not a mycosis fungoides. Good.
very good.
Great case.
Excellent.
Altro no.
Wonderful, wonderful. I
Sebi,
think
Sebi.
When we at Heine Optotechnik develop, improve, and produce our instruments, we first think of the many thousands of doctors worldwide who use our instruments every day. And we think about the millions of people worldwide who are examined with our instruments, the patients. We think about the fact that a good diagnosis must be as precise as possible so that diseases are detected as early as possible. We think about the future of millions of people, and we think about how that future can be a healthy future. That's why we build the best instruments for over 75 years. Heine, quality made in Germany.
I love this
Very nice.
video.
By the way, since it's also the last episode, on the occasion of this video, let's thank very much our sponsors for supporting the happy hour.
Yeah.
Heine, Photofinder, Aven. We thank them very much. And we have, I see that we still have the, let's say, the permanent collaborators.
Yes.
Here, eventually, we have not only Pascal, but also Daria.
Yes. Daria became permanent, exactly.
Yes,
I would
Daria
say,
became permanent.
yeah, yeah. So let's have a look.
My patient, an old, pretty, and a very happy woman. But 3 years ago, she was absolutely unhappy. For the last 20 years, she hasn't left the house. Look closely. What could be the reason? For the last decades, her face was ugly. Her face looked like this.
Oh,
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 wow.
Oh,
oh,
come on.
Dermoscopy corresponds to lentigo maligna.
Never seen such a case like this.
Unbelievable.
Wow.
The most
Yeah.
suspicious areas: punch biopsy, report lentigo maligna with a focus of microinvasion, Breslow 0.4, topical treatment, imihimod, but treatment was difficult for the patient and she refused treatment after 24 applications. Let's look at the way of healing 2 months after the end of therapy. 5 months. Frontal histology after 6 months. And again, punch biopsy. Everything is fine.
Wow.
And finally,
Great case.
it's a new lady, it's a new woman.
Great. Mamma
Perfect.
mia. Mamma mia.
The
What a
patient is
case.
now 90 years old and she's fine.
Wow.
Actually, when
It's
there's
a
enough
happy end.
irritation, it's
Wow.
not.
Wow. Wow.
Nisa,
Daria,
Giuseppe,
if
Emilios,
I have to nominate
Konstantinos, and of course, Sebastiano, I love you. And I already miss the new season of Happy Hours.
We love you so much. You
Love you,
are
Daria.
wonderful.
Daria,
What
I mean,
was this?
come on.
Amazing.
Seriously,
Amazing.
we will ask permission from Daria now that we are ready to publish the new guidelines of the IDS. We will make this case our new flag.
Yeah.
Yeah.
Yeah, that's gonna be the ultimate example of the shift we should do in lentigo maligna management, and we're gonna use it as the symbol case. Yeah, if Daria accepts, which I'm sure she will. I've never seen. I've treated many, but I've never seen such an impressive, wonderful example of what imiquimod can do for lentigo maligna. That's incredible. Thank you.
And
Thank
if I have to
I
say,
need that. The immunological effects of imiquimod continues for about 6 to 8 months, but in this case, it's much more than. And in some guidelines, it's written that no need to take a biopsy after therapy with imiquimod and wait for at least 6 months and then make a biopsy. And this is a great example for this.
That's absolutely good point. There's a great example of this, and this was shown also in the radical study that you should not punch quickly because you might find still some practically apoptotic melanocytes. They remain there, but they are dead in reality. It needs some time so that they disappear completely.
there is a question, can you put imiquimod on the eyelids? Yes, you
Yes,
can.
yes.
You can. Don't be afraid. There is nothing to be afraid of. We advise the patient if the eye is burning to wash it, but it never is the case. So it's really not.
And also, it's quite probable that there is the so-called abscopal effect. Abscopal, I think is the name. So, I mean that I'm not 100% sure that the cream was applied perfectly in all this area.
Yeah.
Probably it was not homogeneously applied in all this area.
Yeah.
It doesn't matter. It doesn't matter. Even if you apply it in parts of the lesion, then it stimulates the immunologic system to destroy also the cells you did not.
Correct.
Yeah,
As our friends can tell, we're not a big fan of imiquimod. Not at all.
Who?
Us, not at all. We don't.
Really? Yeah. Really? Yeah.
Yeah.
What is the duration of
I'm
the
a big
treatment?
fan.
The treatment duration must be, let's say, 12 weeks, but it's depending on the response.
So I think
We
that
published a paper. Even 12 application was enough because we had great irritation, ulceration. So there's no need. I think according to patient's reaction to the therapy, it's important to decide whether to continue or not to continue.
I
Because
think
it's not the same in all patients.
Of course. In Daria's case, I think that she said that they did 24 applications and then
24 applications. Yeah.
they stopped. So 24 applications means
2 months, for about 2 months.
yeah.
Yeah. 3 times per week or every day? Every day. Every day.
I like every
We
day.
perform 5 times a day. 5 times a day.
5 times per week.
5
Use it
times
every
a week.
day.
5 times a week, sorry.
Yeah.
I do every day. They become
Yeah.
so irritated, but then they're perfect.
Yeah, exactly.
Or I add
Wonderful.
topical
Wonderful.
retinoic acid if there is no irritation.
Yeah. If there is no irritation, then there is
Topical retinoic acid.
there are
Yeah.
ways there are ways to stimulate the irritation either with
Mhm.
retinoids or with a little bit of laser CO2 that you can do microtraumas and then you facilitate the
Or
there are
applying with occlusion.
there are ways to do it. Very good.
Wow. This is a
Fantastic.
great case for the last episode, right? I mean,
Yes.
the best case
Amazing.
ever. We cannot
Yeah,
expect
best
a better
case.
case than this one.
Amazing case.
Yeah.
Yeah. And Daria, please give us permission to make it famous all over everywhere. The concentration of imiquimod is 5%. 5%.
Yes.
Very good. Okay, let's see also Penelope.
Yeah.
We have the usual gifts plus one extra because it's the last episode. So we start with the usual gifts, starting with the first one, 73-year-old. Ring light lesion for 6 months on the abdominal wall. That's dermoscopy. We see the vessel.
Beautiful.
We see
Wow.
the fibrosis. Yeah. What's up?
Pincus.
This
Pincus.
BCC, let's say.
I go for irritated sep-K for some reason.
Irritated sep-K. Yeah. A lot of shiny things. But it could be. BCC.
Nodular.
BCC. Nodular BCC. Good. Next one on the chin, 63-year-old man, asymptomatic papular lesion for 3 months. That's the clinically looks like a BCC, I would say, if you agree.
Yes.
Yeah.
Dermatoscopically, not so much because the vessels, as you can see, are rather hairpin type mainly, or even cherry. What's the name?
Cherry blossom.
Blossom. Yeah, a bit of keratin.
There's some pigmentation and
Some
maybe
remnants of pigmentation. Yeah. So,
but there are some milia-like cyst-like structures, white clouds. So maybe irritated
even
sep-K.
irritated seborrheic keratosis. Even
Irritated seborrheic keratosis.
okay. Eccrine poroma is probably a thought because of the vessels. BCC, irritated sep-K.
Irritated seborrheic keratosis.
Of course, also is part of the game. Yeah, other and the
Other. Wow, other. What's that?
What kind of other?
Another adnexal.
No, I think if I remember correctly, what it is, it's a synonym in my view. Monomorphic vascular pattern, radially arranged cherry blossom-like and hairpin vessels around the central mass and small, bright white polarized structures. Inverted follicular keratosis. To my understanding, this is a synonym with irritated seborrheic keratosis.
Yes.
But, anyhow.
Yes.
Nice.
Yes.
Nice. Yeah. Very nice. The next one, 68-year-old man again. His wife, of course, always the wife is concerned about the recently appeared eroded lesion on his right calf. Very fancy lesion with very vivid.
Very vivid, yeah.
Bloody appearance.
Yeah, it could be also a clear cell.
Could be also a clear cell. The vessels are, I don't know, coiled, maybe.
Coiled. Bowens.
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 Vascular pattern of large glomerular vessels arranged in lines, mimicking a clear cell acanthoma.
Yeah.
Very good. Then a really dark lesion in a young
Blue
woman
nevus, blue
of
nevus, blue
dark
nevus.
side, yeah.
Maybe dermatofibroma, firm. Dermatofibroma.
Pigmented dermatofibroma, yeah.
Yeah.
Nodular pigmented dermatofibroma.
Yes.
Very
In a
common.
skin of color patient.
Yeah.
Of color patients, exactly, with network, of course. Dermatofibroma, very good. Fine regular brown pigment network, yeah, described by Pedro several years ago. Would correspond to the initial stage where post-traumatic inflammation predominates. Yes, of course. And histologic correlation, elongation of the reed ridges. Of course, that's why we see a network.
Yeah.
Very good, dermatofibroma. And the last one, 33-year-old man, discrete erythematous papule on his thigh. That's dermoscopy. We see many vessels, coiled, dotted, I think.
Yeah. It's
Mm.
Also DF?
it looks
Bowen, maybe.
it looks
Bowen,
Bowen. Yeah.
Bowen, yeah. Finally, irritated seborrheic keratosis again,
Yeah.
because a bit misleading because of the coiled vessels. But remember that coiled vessels and hairpin vessels are signs of keratinization. So, in fact, we see coiled vessels also in seborrheic keratosis. That's not so
Yeah.
strange. Very good. And in addition to this, we have, first of all, let me show you the map again, guys, because we're gonna see it in the very end again. So please, if you see your country not red, send something in the chat. And then we have also this from Pascal, a humorous mountain-style quiz to close the season 4 of the Dermoscopy Happy Hour. You see here the photograph from a distance. You see that this is widespread
Eh,
problem.
come on, this is a nice infection.
63-year-old man with type 2 diabetes, lesions for 3 months, variable pruritus, spreading from the chest to the abdomen, pubic area, thighs, legs, self-treated with creams, ineffective. What's the only action to take?
Pediculosis.
But,
But
yes,
put the protection, yeah.
exactly. But you see that still Penelope also uses this old system,
Old system.
Canon G16.
Yeah. Yeah.
And of course, it's a party. Yeah.
It's a
Oh,
it's a rave. It's a rave.
It's a party. Yeah. And also the eggs, a lot of eggs, a lot.
Yeah.
Oh,
Some of them are full, some of them are empty.
You.
Yeah. It's a colony of
Yeah.
And the skier side,
The skiers.
the sign. This is the what's that? It's very black.
Yeah, mamma mia.
Very black, a little bit.
This looks like a spider.
Yeah. So size 1 to 2 millimeters, stocky, short, and broad body with 3 pairs of legs, 4 powerful ones at the rear ending, ending in strong, thin claws, adapted for gripping and grasping the hairs. Grayish to light brown colors allow some degree of camouflage on the skin. That's the nymph, black color. The adult louse lives for about 2 weeks only, short, during which the female moves about 10 centimeters per day. And needs similar to those observed in scalp pediculosis, psoriasis, of course, or pediculosis caused by the pubic louse known as crab louse. Phthirius pubis Phthirius inguinalis.
La piattola.
Fantastico. Thank you, Pascal, so much for today.
For supporting us.
All the season that you were always here with us with your fantastic cases. There is a motto that Pascal, somebody wrote in the chat, that there is nothing that Pascal does not have. If you want something, the most crazy thing you can ever think about, just say it, and in the next episode, you're gonna have it. Okay, so
100% invisible for 100% of skincare routines. Dermatological sun care innovation. Aven Ultra Fluid 100% invisible. An ultra-light texture that absorbs in 1 second. An ultra-broad protection anti-HEV blue light. Ultra Fluid by Laboratoire Dermatologique Aven.
Video. Do we have a
Grande, grande.
video? Yes, we have a video.
My dear friends, can I show something to you?
Yes.
Of course.
Just one slide.
Yeah.
Okay. Can you see this?
Okay.
Yes.
This is Evelina from Uzbekistan, and she tells her greetings to you. And every week she attends from Uzbekistan. I was with her 2 days ago in Kazakhstan. There was a meeting there, and I promised her to show her photo to you. So Evelina, thank you.
Ciao, Evelina. Ciao.
Hi, Evelina.
Wonderful. And now we have the last Kahoot. Come on, guys. Who will be the winner of the last Kahoot?
Sabi, we
The last Kahoot of the season.
don't
Yeah.
have any other videos, Sabi?
No, no, we did two. Yeah.
We finish.
We did 2 videos.
Ah,
Really?
Heine.
Did
you want another
It's
video?
a surprise.
they have a
There-
stroke?
There is a surprise.
There is a surprise. Okay. Really? There is a surprise? No, no surprise. Okay.
The surprise was the Daria video.
So
Perfect.
that, okay. She was great.
Fantastic. It was the best surprise. That's true.
Best surprise.
So host live. Last Kahoot of season 4. So a very special winner tonight, because the winner will appear on the screen, and together with all of us will say the last words of season 4 of the Dermoscopy Happy Hour. So it's a special thing today for the winner. I did not share my sound.
You did.
I did. Okay, good.
No, actually, I don't hear.
Do you hear?
No.
Yes. I
So-
do.
Okay, if one of you hears, then it's fine. Okay. So eventually, in the end of the season, also the problem of my account was solved
Yes.
automatically. Okay, I think we can slowly start. 3, 2, 1, and we start with the first one, which includes 2 cases. You see the clinical photographs, you see the dermatoscopic photographs, and now you're gonna see the question. And the question for these 2 cases is, which of them is poroma? Left, right, both, or none?
Poromas are hard.
Yes, we love poromas. We love poromas, and you see that the majority of the people found it. It's impressive, I have to say. It's impressive. The one on the left was the poroma. The one on the right was a seborrheic keratosis, an irritated seborrheic keratosis. And we have S in the first place, followed by deep blue and by Adele. Which brings us to the question number 2. Again, two cases, right and left, non-pigmented. That's dermoscopy. And the question for this one is, which one is pilomatricoma?
Nice.
Left, right, both, or none?
You are very passionate about poromas and pilomatricomas, huh?
Okay, at the end of the episode, we need to say which is our favorite tumor.
Left.
Wow, wow. Wow, wow, wow.
Amazing.
Amazing. Left was a pilomatricoma. What happened here? S is still in the first place, K in the second, and deep blue in the third, which brings us to the case number 3, which consists of 3 photographs. 1, 2, 3.
Which one is dermatofibroma?
And the question is, in this photograph, how many malignant tumors you see? 0, 1, 2, or 3?
Uh-huh. That's difficult, huh?
Please.
For you, not for the audience.
That's so very true.
A little bit also for the audience. 0, 0. So that's a nevus, and a dermatofibroma. So 0 malignant. And what happened here is that S is still in the first place, followed by D
Yes.
and followed by Kaka, which brings us to case number 4. Again, 2 lesions clinically, dermatoscopically. And the question is, which one is the dermatofibroma? Left, right, both, or none?
I guess.
I guess as well, but okay, at 1 second. Okay,
Yeah.
Zebi, which one?
Yellow.
I said both.
Right.
Right.
The left one, I give you a few seconds to say the correct diagnosis.
BC.
BCC. Very good.
Wow.
Yeah.
Okay.
Very good. Okay, Kaka is now first, Deep Blue is second, and Ayers is third. And the final case is this one. That's the clinical, that's dermoscopy. And the question here is, true or false? This is simply a seborrheic keratosis.
You wanted to be gentle for the last case, right? You wanted to be gentle.
And the answer is false, of course. This is not simply a seborrheic keratosis. That was a melanoma, as you guessed correctly. And we have our podium. Third place, Heli. Second
Bravo.
place goes to Ayers. And the winner for today is Kaka.
Deep blue.
Caca!
Bravo.
Grande caca! Caca, show up!
There was a very, very good football player named
I
Kaka.
think this time it is he or she is not a Turkish because
Yeah.
kaka means shit in Turkish.
What does it mean? What does it mean? Shit.
Shit.
Yeah, also
In
in
Turkish.
Italian. Also in Italian.
Also in Greek. Also in Greek.
Yeah.
Who's
Okay.
Kaka?
So who's Kaka? Kaka, come on. In the
Same in
meanwhile-
Germany. In Russia the same. Everywhere.
So he's kaka.
So in the meanwhile, what can we say for the people from all over the world? Look at the map. Every Sunday. That was amazing, from all over the world. The global appointment of so many people from everywhere on the planet. Guys, that's very, really
Yeah.
rare thing, unique. Thank you. We thank you so very much.
Yeah. No,
Here
this
every
is.
Sunday with us.
It's really impressive. Also, the warmness that we get from all the people who are with us for the 20 Sundays at 7 p.m. Impressive. Oh, Claudia,
Yes.
you are Kaka. Ah,
Yes.
Yeah.
This is a nickname in Brazil.
I see. Okay, okay. So you are based where? Brazil, where?
Where Minas Gerais, Belo Horizonte.
Ah, Belo Horizonte. Yeah, of course. Great,
That
great,
was
great job.
great to have a Brazilian
Congratulations.
face.
It was a very challenging episode. And Amelios, I think, is not so generous this time. The questions were very hard.
Yes, it's the first time I go to the first places.
Congratulations.
Bravo.
Very good. You are so
Bene.
good teachers. That's why I win.
Wonderful,
Okay,
Claudia. Wonderful.
ragazzi, you know that I love you more than ever, more
Oh,
than ever.
We love you
Today,
so
less than
much.
tomorrow.
I love you so much, guys.
Guys, and thank you for all the people around us, all the people for sharing with us this about 1 hour on the Sunday, and we will keep in touch, and there will be season number 5, right?
right. Very
Who
good.
knows?
Who
Yeah,
knows?
who
No.
knows?
They're already asking when is the next episode.
We hope so.
Let's say very possibly.
Yes, yes, yes. Ok.
Wonderful.
Ragazzi, un bacio a tutti.
Enjoy the summer.
You
Bye bye.
too. Baci, baci. Ciao.
Grazie.
Bashi, bashi.
Ciao.
Bye, guys. Thank you all so much.
Bye.